Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and a writer that has been working with CCF for 10 years, folks. Actually, check that. I think it's been 11 now, which has kind of flown by. It's kind of wild to think about that. The past decade of my life and career has flown by, but this has been one of the most impactful projects, ongoing projects and relationships that I've had in my career. And I'm so profoundly grateful to be a part of this community. So what I do and what I have done with CCF in those 10 years is create all kinds of video content, live video series and conversations like the one you're going to watch today, patient-centric documentaries, treatment-based videos, event coverage, all kinds of videos, hundreds and thousands of videos that we've created in those 10 years, but all with the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we're here to do today. Now, this show in particular, the value, in my opinion, is twofold. One, the information and the answers to your questions you're going to get from our guests, and two, the shared experiences and shared stories from the community that we have cultivated here. So if you're part of the community, I see you already chiming in and saying hello from Manchester, Tennessee, Rockford, Illinois, from a couple in Tennessee, SoCal, Canada, Illinois, etc. If you are new to the show, new to this journey, reach out, introduce yourself to the community. I promise you, they will embrace you. So before we want to get started, we always like to thank our sponsors, Ipsen Biopharmaceuticals, because we simply couldn't do the show without them. And we have this disclaimer from them we like to say at the top of the program. That is that the opinions expressed today by our guest presenter, as well as the questions that you all at home have asked, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't necessarily endorse or promote any of the views, opinions, or information provided in today's presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. All right. Like disclaimers often are, that's a lot of words, but they really are saying one thing. We're going to give you some great answers to your questions today, hopefully, and some general advice for this journey. But we or our guests don't know your specific case. So take that general advice, take those answers to your question back to your home team, which does know your specific case, and make the best plan and path forward for you. Because although I am not a medical expert, I have learned one thing very clearly in the past 10 years of working with neuroendocrine tumors or working with CCF, is that each case of this disease is unique, and therefore each path forward is as well. All right, we have a new guest to the show today, which I'm very excited to host, Dr. Mariam Aboian. Welcome to the show.
Thank you so much, Rain. It's such a pleasure to be here and to meet this exciting community. I get to work with some of you in my clinic, but it's just so nice to be able to meet everyone across the world and across the US as well, to discuss topics that are important to you and to take these ideas and to develop new ways of treatment. So I'm very, very excited.
So you mentioned your clinic. For those that might not be familiar with you, where do you work and what do you do specifically there?
Yes, so I'm an assistant professor at Yale University. I specialize in neuroradiology and nuclear medicine. I do both adult and pediatric neuroradiology, and a lot of my work is actually in brain tumors. And I am involved in building the new field of molecular neuroimaging. But there's also a big revolution going on right now in the field of radionuclide therapies and how we administer therapies. So the other hat that I wear is leading the Theranostics Center here at Yale and building the practice here for theranostics with Lutathera and of course the newly approved Pluvicto. So we're very excited about that. But another thing that I work on, and this is actually really important for understanding the pathophysiology of disease, is informatics tools in medicine. And the idea of how do we translate artificial intelligence into clinical practice.
Wow.
There's been a lot of exciting innovations in artificial intelligence in medicine. But we found that very few clinical practices actually use artificial intelligence in clinical practice. And we're figuring out ways we can apply artificial intelligence to clinical practice and ways we can do this safely. This allows us to do very precise therapies for patients because we're able to then monitor patients, not just their disease from an overview look. We can actually tell you which tumor is growing, which tumor is getting smaller, which tumor is getting bigger, at what time frame,
Wow.
and how we can do therapies for those particular tumors in those locations with the informatics tools that we build. And I can answer a lot of those questions if you're interested in that.
That's exciting. I'm interested in that particularly because I don't know that much about that specific space. So I know that you're going to get a lot of questions today about PRRT and similar topics because we get them every week. So folks at home, hopefully that guides your questioning a little bit, understanding where you're going to get the most value from today's show with our guest today specifically. And listen, the show, as soon as this show is over, it's going to post itself onto Facebook. It'll live there evergreen under the videos tab. Starting next week, I'll put it onto YouTube for anyone who doesn't have Facebook. So the replay will always be there if you want to go back and watch it, or if someone misses today, they can watch it. But the real value is being here and getting a question asked that you may have been struggling with, or your home team may have been struggling with, and having this interactive one-on-one session. So if you know someone that should be here, maybe you don't see them yet in the comments, tag them in the comments, let them know the show's going on, remind them that it's happening. Let's get as many people here as possible. Couple other asks that I have of you before we start the show. When you're asking your questions, it really helps me do my job better, which is, of course, to get those questions answered, because we inevitably get so many that we can't get to them all. But it helps me ask them if you phrase them in a general way. So we can't answer your very case specific question. So if it's super dense with all this very specific to your case alone information, it doesn't actually help us. And I understand that you're struggling and we want to get those questions asked. And after the show, you can send a message to CCF and we'll still try to get you that help. But in this format, the easiest way that we can do it is to guide you kind of to the next step along that journey. And then if you have a follow-up question, ask it and we'll answer that too. So in little bites, little pieces like that versus, 2 or 3 paragraphs with all the different, metrics of your disease. It just helps us out a lot more. But our goal, hear me out, is to get all of those questions answered, but it's just easier in this format to do it in little chunks like that. And then the second ask that I have of you all, and I ask every week, and you do a great job of it, is if you see a question in the comment section that you also have, just under it, you can like it, love it, any of the emotions that Facebook allows you to use. They all work effectively the same way for me. And that is to upvote that question. If I see that 8 people have that question as I'm scanning the comment section, I'm going to make sure to get that one across. I don't want to miss that one. If with one answer, we can answer at least 8 people's question, right? We're going to get more bang for our buck. So just a couple rules of the game. Otherwise, go ahead and start sending in your questions. Let's have a chat. I see you all saying hello from all over the world, waiting from some of our international friends, which inevitably will be here. Hello to everyone who are regulars, and anyone that's new, hello to you as well. So I have a question first, Dr. Aboian. We were chatting a little bit before the show, and we were talking about the format since this is your first time here, and you had mentioned this comment, and I'm paraphrasing. This isn't exactly what you said, but like, you really love these interactions with the community because of what you get from them. So today's show is all about like you helping them, right? But you really brought up this point that I love so much about this community, about how, and you said something, I'm paraphrasing again, about how you learn from the community, and actually it guides your work and it guides your research. That's really interesting to me, and I want the people to hear that in your words, so they understand that their talking, their communication, their conversations are actually impactful on the whole overall process. Can you tell me a little bit more about how you feel about that?
Yes, it's actually really interesting when you go through your training in medicine. You think when you're a medical student, you think that when you become an attending, you know everything and you are able to do everything. And then
Right.
you become an attending and you realize that you know nothing, and you have to keep learning. And what's really been exciting in my practice When I came to Yale, it was a completely brand new place for me. I come from University of California, San Francisco, where I did my residency and fellowship training, and I did my medical school training at the Mayo Clinic in Rochester, Minnesota.
Oh,
So when I came to Yale, I was starting out. I was trying to figure out what I needed to do. And I remember I was reading a lot of the scans on brain tumors. And I have a lot of training in brain tumor imaging. But one of the things I noticed is you're looking at brain metastases and you're trying to figure out, is there progression, or is there no progression, or is it there pseudo progression? And a lot of times I get messages from patients as a radiologist, usually through their oncologists. And a lot of times the oncologist would say, can you make a definitive statement if this is a progression or pseudo progression, or this is stable disease? And one of the things I noticed is that it's really hard to do from imaging, even after going through 4 years of radiology residency and 2 years of neuroradiology fellowship and 1 year of nuclear medicine fellowship. So I decided, can I do this in my lab? So I started first measuring the size of all the brain metastases. And some patients have over 100 brain metastases. And I would measure them all and put them in an Excel sheet and track their growth over time. And it would take me a full day to measure a single patient, which was not working in my clinical practice because I have to read multiple scans per day. So I started working with our informatics team and developed tools in our visualization system that we use to read studies that use machine learning, and which is a form of artificial intelligence, to automatically measure all the lesions and list them all in a report. So then all of a sudden, we were able to start applying the research metrics, which are the RECIST criteria, and for brain metastases, they're called the RANO brain met criteria, into clinical practice, which has not been done before, which is very, very exciting, because now my oncologists get treatment response curves on the brain metastases. And they're able to see if one lesion is behaving differently than all the other lesions, then they can provide precision therapy for that particular lesion and leave the other ones alone. While if all lesions are behaving the same, then they can provide systemic therapy and provide overall therapy. And all of this happened from feedback from patients like you, because we didn't have these tools available, and now we do. And I'm really excited to learn more so that I can take these ideas, and I know you have a lot of really exciting ideas, because all of our patients have a lot of great ideas. And then I can take them to my lab and develop them so that it comes back to you in a way that you need.
Outstanding. I love that. Thank you so much for sharing that perspective. I think it's so important. And listen, I don't have like extensive experience with, I have some experience with other cancers, not extensive, but my hunch is that this is somewhat unique to NETs. Hopefully it's not, and it's carrying over to other spaces, but I know it's definitely evident in the NET community for sure. And so I mention it every week. The folks that attend every week know that this is a point that I like to focus on, because I just think it's so special, but it also helps us all move further along in this. So I appreciate you sharing that. And speaking of other cancers, I have my first question. Folks, if you just joined us or joined us a little bit late, we are here with Dr. Mariam Aboian, and we're talking about all things, PRRT, nuclear medicine, etc. But we have a question about PRRT, which I knew we'd get a lot, but this is interesting. Bethany says, can you talk a little bit about how PRRT is being used to treat other forms of cancer? Can you share resources for reading more about that potential or current application? And then she mentions, as a side note, this question stems from a comment my nuclear med doctor made about how NET treatments are and have been paving the way for cancer treatments in general. Woot, woot. And this is a side note that I'll add. This is interesting to me. I have a cousin who is now certified, I don't know what you call the person, in delivering Lutathera, and she was posting about it on Facebook, and I was like, wait a minute, what, you're talking about Lutathera? This is something I talk about every week. So it was just wild. And she does not work with NET patients. So what are your thoughts on this? This is an interesting comment.
This is a great comment. Actually, this is exactly underlies the main theme of theranostics, and um, and it's amazing that it has only become available more widespread use recently. Granted that it has been developed a long time ago, but the main usages have been more recent. And the idea is you can use an agent to visualize disease. Then you can take the same agent that targets your therapy to the tumors and exchange the radionuclide for a therapeutic radionuclide and use the same drug to deliver the therapy. So you know exactly where the drug goes. And after the therapy, you can actually see where the drug went. This has not been available before because when we do regular medical therapy, we don't know where it goes because there's no way to visualize it. We just know it goes somewhere. And even if we target it to a certain location, we still can't see it. With PRT, we can actually see where the therapy went. Now, when Lutathera got approved, it did open the floodgates because all of a sudden we can use other tags to localize the radionuclide, and we can use other radionuclides to visualize and treat patients as well. So one of the things that actually Lutathera has been used for is meningiomas, because they do express a lot of somatostatin receptor. And there's a lot of very exciting work being done on that. And a lot of times, most of the community thinks that meningiomas are super benign. There's nothing that needs to be done. But there's some meningiomas that are extremely aggressive. Even though they grow slowly, it doesn't mean that they're not something that should be, there's something that should not be treated. So it's definitely something that's one of the targets for Lutathera. But it turns out there's a lot of somatostatin expressing tumors out there. And how, can we treat them with Lutathera? And can we get response from them? And there's still a lot of questions like this that are still unanswered, and we need to be answering them in our research. And it's not just Lutathera. So PSMA is expressed in quite a variety of tumors, not just prostate cancer. It's expressed in many, many different tumors because of altered vasculature in those tumors. Can we use lutetium PSMA to treat other tumors? Can we use PSMA to visualize other tumors, right? We're trying to use to see if we can use it in glioblastomas. Can we characterize glioblastoma characteristics better with PSMA? And of course, there are other potential targets that can be used for visualization and therapies. But what was really great about Lutathera is that it really established the proof of principle that we can do this kind of approaches and open the doors for us to start trying new things. So I would just keep an eye open because this field is really, really growing and expanding.
That's exciting. Thanks, Bethany. Next question. Okay, now we've got a lot of them coming in now. So Greg says, how common is it for neuroendocrine cancer to metastasize to the brain?
Oh, that is a great question. It's actually fairly uncommon for it to metastasize into the brain parenchyma. It will go to the bones, but some in the head and neck region or skull base, but not necessarily to the brain parenchyma. But the one thing about cancer is that never say never. So there's always the rare cases where something can, where metastasis can happen to the brain parenchyma, but those are extremely rare. But when it comes to trying to figure out and learn lessons from these kinds of cases, it is very important to keep track of these rare events. Particularly keeping track of events that are underreported, and particularly underreported in the literature, because they do provide us really important information. An example of that is I had a patient who was a long-term survivor from glioblastoma. And we know that glioblastoma is an extremely aggressive disease with very poor survival. But this patient lived for many, many years. And it turns out they were quite an activist, and they formed a community of patients who are long-term survivors of glioblastoma. And this is a very large community, it turns out. And we as physicians, we don't see these patients as often. And a lot of the times, their experiences are not documented. And a lot of times we'll say, oh, you can't be a 10-year survivor of glioblastoma. You must have been misdiagnosed, because that's not what my textbooks taught me. Right? But what if we missed this patient in the study that we designed? And I would love to hear, maybe not a scientific study, because it's hard to do a study, but maybe case reports, maybe even literature reports, maybe even somebody could write a book about this, because we need to follow these rare cases. And if we can find ways, unique, creative ways to find these patients with unique presentation of disease, we can then start trying to figure out how this happened. And maybe we can target that mechanism or activate that mechanism. Suppose a patient is a long-term survivor of glioblastoma. Is there a way we can provide the same kind of pathway in a patient with poor survival and find therapy that way? If we never know when science opens doors to us. The thing with science, you walk around with eyes closed, and you hope that the doors will open to you. But the only way they will open to you is if you keep trying and you do it with a pure heart. So these alternative ways of describing your experiences and communicating it to the scientific community, priceless.
What did you say? What, and a pure heart?
Pure heart when it comes to research. You really have to have that.
And with like a perspective of curiosity, instead of just like this shutting the door of like, no, I've never seen that before. And this, this answer you just gave, it ties back to that theme that you said in the very beginning of like the experiences and stories and conversations from the community help guide your research and your work. And I think that's evident in that, and encourages people. And I know the net community knows to do this, right? But to share those experiences. I've seen it here on the show where we've talked about a topic. It doesn't really matter what it was. I think it was carcinoid rage or something like that, where the doctor was like, there's nothing to really show that that's a thing. And all the people in attendance were like, it's a thing. And he like laughed. He was like, okay. So yeah, I think that's such a good point, and a part of what the net community does really, really well. So yeah, thank you for adding that. And thanks, Greg, for your question. A few other people had that question too, so I'm glad we took it. Okay, so staying with the brain, Joey says, my dad had brain radiation for 10 days straight to the full brain for a 2 millimeter spot. How long until his taste comes back and this brain fog gets better? And is there anything that we can do to bring back his taste? He's on Namenda to help.
Wow, what a great question. I'm sorry, what is your name again?
Joey,
thank you so much for this great point, because we don't talk about the brain fog after radiation very often. And we don't talk about focal side effects from radiation very often, because radiation is life-saving, right? We do radiation therapy for brain metastases, for brain tumors, primary brain tumors all the time, and it does provide extended survival. But it's a fantastic therapy, but there is a significant side effect that happens, and we can call it brain fog. We can call it radiation-induced cognitive decline. And I actually just wrote an NIH grant to study why does radiation induced cognitive decline happens. And I spent the last 2 years thinking about this, just writing this grant, because when we think about it, some of the common theories for this are there is loss of neurons in the hippocampus. And the way that those studies were done is when researchers took mice or rats and they would irradiate them and then resect their hippocampus and look and basically count the neurons or count the synapses and see and show that there's a decrease in synapses. Well, it turns out that there's more than just hippocampal neuronal loss. It turns out there's multiple processes that happen. One of them is disruption of the blood-brain barrier. So toxins can get to the brain more commonly, more easily, the ones that usually don't get to the brain, and that can cause brain fog. There could also be damage to the vessels in the brain that can cause brain fog. Now, another thing that can happen, these cells that form the sheaths for neuronal axons, they can die off, and that can cause, so there's white matter damage. So that can cause brain fog. But it turns out there's also gray matter damage with synapses that can cause brain fog as well. And right now, how can we figure out the mechanism of this without doing a biopsy, right? And why would you want to do a biopsy on a normal brain? That is not something you want to do ever. So we do a lot of that research in animal models. And the way I am studying this, actually, I use a novel PET tracer. So similar to like gallium-68 dotatate PET, I have a PET tracer that localizes to synapses. And we're looking at dynamics of synapses in the entire brain. And we're starting to see that the way synapses change after radiation is not what has been described classically in the literature. There's a time factor to it. And we're very excited to resubmit this NIH grant. I'm going to be resubmitting it in September to try to decipher what's the dynamics between synapses and axons, and can we find synapse preserving therapy or axonal preserving therapy? And is there a way we can find a time when this therapy will work and when this therapy will not work? Because that can really change how patients recover after radiation therapy to the brain. Right now, what we have is we can use memantine for treatment of this brain fog. We can also try to target the therapy to a very small location, but depending on where that location of the brain metastasis is, it can have also side effects, like it can hit another nerve that can cause taste sensation problems, or another kind of neurological findings. So how long does the brain fog last? Usually patients do recover from it about, I believe, after 6 months or so, but we don't know if it comes back to complete normal. And there's still so much to study in this. And we're hoping we can find new PET tracers that can give us some prediction of when brain fog goes away, and also give us some prediction of preventing it. Because if you have brain fog, you're going to have a hard time taking your medications. You're going to have a hard time with your quality of life. You're going to have a hard time sticking to your therapy regimen, and that can affect outcomes of your treatment. So it's a very important part of our treatment.
Got it. Hey, thanks for your question, Joey. So this is similar, but not the same. Terry says, how long does radiation stay in the body?
Oh, that's a great question. So this is a two-part question. One of them is what is the half-life of radionuclide? So how long does it, in very general terms, how long does the radioactivity of the nuclide halves to itself by itself, just by physical properties? And then the second part, how does this radionuclide get excreted from the body? Does it get excreted through the kidneys, so we pee it out, or through other systems? So it's a combination of these two processes, and there's a formula for that we can calculate. And that basically defines how long the radionuclide will stay in the body. And for different radionuclides, it will be different. And usually we'll provide little cards after the therapy for how long you need to take precautions and what kind of precautions you should be taking. So in our nuclear medicine clinic, we will give a little sheet of, double flush your toilet for 7 days and that kind of things. And this is why we talk about toilet techniques all the time because a lot of the radionuclides gets excreted through the kidneys. So even a drop of urine can cause contamination, and you definitely don't want to be, for that drop of urine to be close to a pregnant patient or a little child or even a companion dog or anything, and those kinds of things. So we do ask there's a lot of discussion about making sure that urine doesn't get contaminated anywhere. As you may have experienced in the therapy cycles of this is a major topic of conversation that we have, but it's an important one because that's
Definitely.
a way to get the radionuclide out of the body.
Absolutely. And Terry has a second question. Does PRRT cause weakness or fatigue?
Oh, that is a great question. So when we think about weakness and fatigue, it is a very multifactorial process.
Mhm.
So many things can cause weakness and fatigue. But one thing with PRT, when you receive any kind of therapy, it can cause weakness and fatigue. The one thing you want to watch out is when it's severe, and that's really hard to assess. What do you mean severe weakness, fatigue, right?
Yeah.
And when we like to think about it, we try to say, well, is it any different from your usual state of being? That's also really hard to assess
Right.
because it can be different in July than in January, and can be different one week from another in just general life. But one of the side effects that have been reported with PRT is effects on your blood and red blood cells, white blood cells, platelets. And when they do drop, and this happens in very rare cases, but you can have weakness and fatigue that can be severe. So this is something that we do monitor our patients for, and we try to estimate in terms of, and really have the patient guide us in how bad the fatigue is, and correlate it to their CBC lab tests to make sure that we don't need to intervene.
Got it. Thank you. Another similar question. We talked about brain fog earlier. So a lot of people are, like I said, are interested in these topics you specialize in. So Bridget Ann, which by the way, Bridget Ann, I see you working and tagging people in the comments like I asked. So thank you for that. She says, any research about memory loss, short or long term, from PRRT? And she adds that I do have cells in my skull. And I've shown brain shrinkage. My neurologist and psychologist can't find another reason. So is that related, do you think?
Bridget Ann, you're asking a key question. If we can solve this, we'll get the Nobel Prize. But I agree. This is a really, really important question in the field. So in addition to radiation-induced cognitive decline, there's also an entity called the chemo brain. So when patients get chemotherapy, they get brain fog as well. And and we're still trying to figure out the mechanisms for that as well. And this is where my lab is heading towards. We're starting with targeted radiation-induced cognitive decline studies, but we're planning to head into also chemo brain and seeing how chemo with radiation combines in causing cognitive decline. And we still don't fully understand because we don't know the dynamics of white matter and gray matter. Now, there's also other causes for volume loss in the brain. One of them is just age. You can have some volume loss in the brain, but another is neurodegenerative disorders. That they're actually extremely common, and they cause very characteristic types of volume loss in the brain, and also very characteristic imaging patterns on FDG. And we also have additional tracers to image amyloid deposition or tau deposition. And trying to when we look at the neurodegenerative diseases, we try to figure out which pattern does this patient look like, and then diagnose them based on that. Now, the problem with so there's a couple of patterns that are very clear, such as Alzheimer's disease, right? But there's also patterns that are very difficult to diagnose with imaging, such as autism spectrum disorders or psychiatric disorders. They do show changes on imaging in research studies, in protocols that are extremely delicate and can only be done on research scanners in specific places, really. And we don't usually do those kinds of protocols in clinical practice. In my neuroradiology practice, we only do the basic imaging, and pretty much across the US, when it's a clinical practice, we don't do these high-end protocols usually. And particularly because they're variable and they're not fully proven to show consistent results. So we would need to have these protocols FDA approved and then incorporate them into our clinical practice. And then the other thing is a lot of these advanced protocols have to be read by a specific expert. And even in neuroradiologists, which is a very specialized area of expertise, and a neuroradiologist who's trained both in nuclear medicine and neuroradiology is even more specialized. I wouldn't be able to diagnose a very rare disorder from basic clinical imaging, because a lot of times on our basic clinical imaging, we don't see an abnormality, and we would need a very specific protocol. And the truth is those protocols are not always reliable and not always translatable to clinical practice, but we're working at it. One of the things that we're working on really translating is DTI and fMRI for preoperative therapy planning for brain metastases. We also, and those are very common in clinical practices, and they really help neurologists and neurosurgeons with planning their surgeries, and also planning in terms of the kind of physical therapy and occupational therapy that would need to be done afterwards. And then we also try to include very advanced perfusion protocols. We're instituting cerebrovascular reserve protocol here at Yale, which is only available at a few centers in the US. And the idea is to look at what is the reserve of patient what is the cerebrovascular reserve for a patient, and will they develop a stroke in their future. So those kinds of advanced modalities, they take a long time. Yep. Example of cerebrovascular reserve, we started talking about implementing this 2 years ago, and we're only now starting to get really moving along in terms of making sure that we have all the proper equipment, which is extremely expensive, the staff to do the studies, and to really implement this as a program. And this is everywhere. This is how sometimes it's hard to bring novelties into clinical practice.
Sure. I just want to jump in for a second, Dr. Aboian, and let you know that you can't see this because you don't see the folks on Facebook, but there's been a lot of hearts and thumbs up and likes and all these emojis that are used. People are really appreciating it, and comments saying how interesting and informative today's presentation is. So just wanted to let you know that the people are speaking and they are very excited that you're here. I also think that this is a really good and kind of unique episode, so I'm excited as well. Now, when you just started answering that previous question, a comment came in almost simultaneously, coincidentally, from Gene that says, what about chemo brain? Does that ever go away, and why does it happen? Is it the same as radiation? Now, I know you covered a lot of that, but I just wanted to pose that question in case there was something else you think needed to be added that will help, help Gene out a little bit more. Or do you think you kind of covered it all?
I would love to hear Gene's perspective, actually, what his experience has been with chemo brain, because it is still such a black box. There's been tremendous advances done by Dr. Michelle Manji at Stanford University, who I really look up to in terms of her literature, in terms of figuring out the mechanisms. And I'm very excited to study this from the whole brain perspective, but I'm always eager to hear what people's experience are with chemo brain, because it doesn't get talked about so much. And it's really hard to get the true experiences from the literature, because we as physicians sometimes don't hear our patients as much as we should.
Yeah, well, this is back to what you said earlier about like speak up. And if yours is one of those rare instances, don't just take it as either it's not true or something like that, but share those stories. So, Jean, this is a good opportunity. I know you're probably still on the call. You usually stick around. If there's anything specific you wanted to ask about it or experiences that you have had with that, please share if you're still on the call, and I'll make sure to get that across to Dr. Aboian. Let's see, there was a question I had just found. Yes, this is from Karen, who is a friend of the show, always here pretty much. I just finished 10 treatments of radiation on my tumor on the spine, L11, L12. The question is, which is kind of a broad question, like, how do I know if it worked? So let's talk about the process there. Like, once the treatment is done, like what happens then? How does she know if it worked?
Well, first of all, we need to know which kind of tumor it is. And I assume it's a neuroendocrine tumor because this is the platform, right?
Mm-hmm.
And what kind of expression pattern of somatostatin receptor did it have? So that's another one that is important to know.
I think if I remember, Karen, do you not have receptors? Like, I feel like I see a lot of, she's here every week. I see a lot of questions, but let's just try to field it in general terms first. But
in general terms, so when you're talking about spine tumors, there's a couple things we think about. Exactly where it's located. Is it in the vertebral body? Is it in the bony elements that surround the cord? And does it go into the spinal canal? And if it does go into the spinal canal, does it compress the cord? Or does it compress the cauda equina, depending which part of the spine it is? So when it compresses the cord or cauda equina, that's an oncologic emergency, and that will require immediate surgery to try to decompress so that you don't lose function of your legs or arms. So we definitely, depending on which part of the spine it is at, those we treat that way. If it does not compress cord or cause edema in the cord, but we catch it early and we start treating it, there's a couple things you want to look at. One of them is CT scan. And I know for spine, we always talk about MRI, but CT is actually really important because it tells you how the bone is doing around the tumor and if there is a fracture associated with the tumor. Because if there is a fracture, then there needs to be additional consideration from an expert in spine surgery to decide whether there needs to be stabilization or not, or any additional therapies. Now, we can follow that up. The problem with CT, we don't see the parenchyma of the tumor very well because it's really good for bone, but not so much for parenchyma of the tumor in the spine. So then we will go to the MRI. And classic MRI that we usually do is with and without gadolinium contrast. So without gadolinium contrast is a really great modality because we can look at bone marrow, we can look at neural foramina, we can look at extent of the tumor, we can see where the tumor is in relation to the spinal cord, we can see exactly where it's extending and how much needs to be treated. We can delineate the tumor, so we treat just the tumor and nothing else with radiation therapy. That is really, really helpful. But what happens is after radiation therapy, the tumor doesn't just go away right away. What happens is there's all this tissue that we call post-treatment changes. And what happens, you can have inflammatory cells going in there. And just because the tumor doesn't change size, it doesn't mean that it didn't get treated. So we try to use additional imaging modalities. So we try to see with gadolinium contrast and also try to use time to our advantage. So over time, inflammation goes away. And if the tumor maintains gadolinium contrast enhancement over a long time, we know that there's still residual tumor in there. So post-treatment imaging with MRI sometimes is complicated. And sometimes we have to say, I don't know if this is treatment recurrence, if this is treatment response or tumor recurrence or some residual tumor. Let's do a follow-up. So we usually will try to follow up these cases because the one thing we know for sure, if tumor is there, it will keep growing, right? But if tumor is treated and all we see is just post-treatment changes, that will involute and will not grow. Now, the other thing that we can do is nuclear medicine studies. So if the tumor expresses a specific marker on its surface, such as somatostatin receptor, then we can do a gallium dotatate study and see if there's any tracer uptake. But for that to really be a good test, we have to do a pre-therapy imaging and post-therapy imaging and compare the signal afterwards. And usually in neuroendocrine tumors, you can have pretty avid dotatate uptake. And then if it goes away, then you would say, okay, this is a treated tumor. Another thing that is kind of interesting, a lot of the times the treated tumors in the spine will develop sclerotic changes on CT. So just because a tumor is sclerotic on CT doesn't mean it's an active tumor. So in cases of breast cancer metastases to the spine, a lot of times we'll follow them with FDG PET. And we can see if they're hypermetabolic. And when we do follow-up imaging for breast cancer metastases in patients after therapy, if the PET signal goes away, if the hypermetabolic activity goes away, but there's still sclerotic change in the bone on CT, we consider that metabolic response and that this is a treated tumor most likely, especially if it doesn't grow over time. So basically, post-treatment tumor in the spine is one of the hardest topics to figure out and is very case-based, very tumor-based. And, it would be great if there's a way for you to talk to a radiologist. And I know that's not part of our standard of care in medicine where patients usually don't talk to radiologists. But I've noticed that for some patients, I've actually sat with them and showed them their images. And it really, first of all, the patients who I show the images to, I'm always amazed at how expert they are in their disease. A lot of the times they'll teach me about their therapy and about what they went through. And I can teach them about the extent of the tumor, where the tumor is, how it looks after the therapy. And that has helped with how they decide to proceed with further therapies in their discussion with oncologists, because you are experts in your disease. You really are, after going through a number of therapies. And you are an active participant in the therapy planning session. So seeing the images just has this magic effect of really helping in making decisions.
Love it. Love it. Folks, we still got a little more than 10 minutes left, so keep those questions coming. Next one, Dr. Aboian from Debbie says, my husband was just given news that his liver is full of tumors and the head of the pancreas. I'm sorry to hear that, Debbie. Would he be a candidate for a second round of PRRT? So this really, the question is, like, I know in the States they have, certain approach to this, and internationally there are, other ways of doing that. What are your thoughts? What are the parameters or criteria? What's the typical approach to rounds of PRRT?
You're asking a great question. Wow, every single one of the questions you're asking
Told you.
two major discoveries in our field. So we still don't have true guidelines on when we repeat cycles. And by cycles, I mean the entire cycle of therapy, all the 4 treatments. So it's really individual center dependent and individual provider dependent on how the cycles will be decided, and also how the first response was and how the treatment was tolerated. Those are the issues that are being in consideration. So it depends. Unfortunately, I can't really tell you, but I do. It is important to sit down with your oncologist and nuclear medicine physician with your images available and your lab values available, and have a heart-to-heart discussion on what you would like, what the goals are, and how you would like to proceed. There are a couple of cases. So there are a couple of cases that I've seen in my training where you have to be very careful about repeating the cycles, because there can be a flare phenomenon that can obstruct some of the vessels and cause ascites to get worse. So those things need to be considered. You really need to be treated as a whole holistic patient by your oncologist, your nuclear medicine physician, and decision needs to come from you as well. And this is where seeing the imaging is really, really important, and seeing your lab values is really important. And the other thing that I do want to say, if there's something doesn't feel right, it's important to seek a second opinion, because it's really important to develop that trust, the trust where you know that you're getting the right therapy, and that the therapy that you agree with. So this is so if in the first set of discussions it doesn't feel right, there's nothing wrong with getting a second opinion as well. But I think it's going to be a very personalized decision. But hopefully in the next 5 to 10 years, we will have better guidelines for when to start therapy and for when to repeat the cycles. When is it safe? When is it not? Right now, we just try to work together with our patients and figure out what works for them best and what makes sense scientifically.
I had a comment from Bethany that this is in reference to a previous question recently. She said, "Yes, I love seeing my images. My radiologist conversations have been really helpful at key points during my journey." So just echoing what you had mentioned.
Oh, that's great, Bethany. I'm so
earlier.
glad to hear this. I'll tell this to my department chair. We really need to have this kind of service started, because this is such an important part of patient care, and there has to be a way to incorporate this into clinical practice.
Yeah, and Brian actually plus or adds on to that, trust plays a major role in your healing and recovery. I think that's a really good point. That's, not often shown in the textbooks, as we've kind of said earlier, but that collaborative, effort between patient and provider, and that trust is, I think it's very, very key. And you know what else? I've been reading a book lately about this too. And these are one of those things that aren't documented as, the objective, facts of treatment, but community and connection. And this is what I specialize in as a storyteller. Community is actually it helps people, I'm not trying to speak out of turn here, but it's been shown to help people live better, longer, more fulfilling lives. And so this is why I say at the top of every program, this is twofold: the value, the information you're going to get, but also the community that we're cultivating here. Look just today at the unique experiences that have been shared and discussed by Dr. Aboian and by the people in attendance. And I think that's so important to, as Brian said, to your healing and recovery as well. Before we go, we have a few more minutes. I wanted to learn a little bit more, Dr. Aboian. I've been working with CCF for about 10 years. I know what's happened in that 10 years in the net space, which is a lot. PRT being one of the huge ones, right? In 2018, at least here in the States. I know it was available in other countries before that. Let's look forward a little bit. Since you're so involved in research, what are you looking forward to? What excites you about the next couple of years, maybe stretching out to maybe the next 5 years in this space? Where are you really excited about people's time and energy and focus and funding going right now?
Oh, wow. This is, it's really fascinating how we think how advanced medicine is right now, and actually how limited it is right now in reality.
Fair point.
So I want RECIST criteria available to every patient. I want every single patient to be able to have a treatment response curve for every one of their tumors, so that they get this sheet, like, how we get the growth curve for our children when they grow up. So I want to make sure that every single tumor is tracked and it's provided as a curve to our patients. And because in our community, everyone is extremely educated in their disease, and they're very interested in learning about the disease. So having these kind of quantitative metrics for patients to be able to follow. So what is this spine tumor doing? Or what is this pancreatic metastasis doing? Or what is this metastasis in peritoneum doing, and how has it been changing over the last 6 months, year, with the different therapies that are doing. And also a lot of our patients are doing alternative therapies and the therapies that are not regulated. And a lot of times we don't know that they're happening, but the patient knows. So if they have these quantitative metrics, they can see, I've been doing this lifestyle change. It would be helpful for them to have these metrics available. And we never know where discoveries are going to come. Maybe there is some kind of a therapy that's natural somewhere, and maybe there is an active ingredient in there, sort of like how penicillin was discovered, right? So these kinds of metrics need to be available to our patients. Ability to see their scans clearly and have a human being explain them to them, not the radiological report, which is really a legal document, a document that can be used in legal cases. So we are extremely vague in our reports because it's not meant to talk to patients. But if we can have reports that are meant to talk to patients, such as video reports or ways of sitting down with our patients and really discussing their disease in terms of how it looks and where it is, and providing these kinds of metrics to our patients can teach us what is working for them. Our patients that are long-term survivors that we don't know about can tell us, hey, you need to study this part of the disease because this is where the answer is going to be.
This is really interesting to me. So many comments. We'll send them to you tomorrow, or commenting on this unique episode. I'm so excited about it because we started off talking about radiation and theranostics, but it's really turned into this this conversation about how to help providers do their best work. Which Ursula, our friend from South Africa, chimes in, says, I have an amazing nuclear specialist, and we chat on WhatsApp. And she is always ready to give advice and answer questions. I'm blessed to have her on my journey. So, I mean, I think we're seeing more of this, right? And our friend Brian, who we already mentioned earlier, said, I provided the information and this show to his oncologist the past week for other NET patients he may treat. And I discussed with him the great community of support we get from CCF and Rain and the guests. And Brian, I just had to say, this is literally why we do the show. And I appreciate you doing that so much. And this is why we have on guests like Dr. Aboian. This is the reason. You're the reason. And what you just did was the reason. So we're really changing things out here. That's very exciting to me. And it's impossible without you all at home doing your part, which is to speak up and to share and to do, not just to sit by idly. And I appreciate you all. Jesse says, I absolutely love your perspective. I so wish I could have this kind of care. So the people are speaking. They really appreciate you being here. We're going to send you these comments. They're so great. Okay. We got 2 minutes left. I want to stay in this space. If I was a early patient, first time patient, I just got diagnosed last week. I don't even know what neuroendocrine tumor is. I've never heard of it. I'm confused. I'm scared. What is your initial advice for that newly diagnosed patient when they're just starting this journey, in terms of approaching this, in terms of dealing with this, psychologically, emotionally, in terms of being their own best advocate? What's that first step?
My mom had cancer diagnosis in medical school, and I was in medical school. I was at the Mayo Clinic. I had the best teachers. I had everything. And when she got diagnosed with cancer, I was in the lab studying cancer. And I remember the first thing that came to my mind, it was this brain fog. I stopped being able to process anything. Yeah. I couldn't figure out. So my recommendation is be gentle with yourself. Just be gentle. It's going to be a long journey, be kind to yourself. Surround yourself with the community, such as CCF. Surround yourself with people who will advocate for you, people who will be there for you when you are not sure what your doctor's saying. Just be gentle with yourself and keep walking, no matter what it is, no matter how hard it gets. Tomorrow's another day.
Mm-hmm.
And just keep walking, because sometimes new roads appear out of nowhere. And that was with PRT. So just be gentle and keep walking. Keep asking questions.
So beautiful. I'm so glad I asked that question. That's our show for today, folks. I hope that it is clear that this is not a lecture series. The power of this show, I'm so emotional right now, and I just love you all so much, and this community is so strong, and I feel it every week, and I appreciate you all being here. Dr. Aboian, thank you so much for being here. Folks, now I can tell you, she was a little nervous, believe it or not. And I told her, I got you. This is what I do. I'll be your spirit guide, but please let her know how amazing she did today. Look, you don't see it, but the hearts are just flooding in right now. Thank you so much for spending time with us and sharing not only your knowledge and your experience, but just your perspective on this. Thank you so much.
Thank you. Thank you.
Absolutely. And folks, you at home, thank you as well. As always, we hope this program helped answer some of your questions. I want to say before we go, you can, you'll always be able to watch this show again. And some of you might, this is every week, might ask questions that don't get answers. I see you asking them again. I just want you to know, I do see you. I hear you. Sometimes it's not the appropriate question for the specific doctor. Like in this case, we had a couple of questions about like lung nets, and this isn't exactly where Dr. Aboian works. And we talk about that beforehand. So two things. One, we have a video for every topic you can think of, not just Luncheon with the Experts, the videos that I talked about at the beginning of the program that I've produced. Go to the videos section on Facebook, or there are Carcinoid Cancer Foundation's YouTube channel. You can find it. Or we will have lung nets, this is just an example, specialist on the show as well every week. So if it's not the right person for your specific question, come back next week. Most likely we'll have on an oncologist or somebody who can field those questions. So don't get frustrated. I see you, I hear you, but everything is designed and everything is for purpose. So stay with us. And I promise you, we will work tirelessly to get the answers that you are seeking. That's our job. Finally, thanks to our presenting sponsor, Ipsen Biopharmaceuticals, without whom this program would not be possible. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye now.